there, I'm Jamie Carr, and today I'm going to be doing the cardiac, peripheral, vascular, and abdominal assessments for 505. So after proper hand hygiene, I would ask the patient 2 patient identifiers and ask for consent. So I'm not going to make you identify yourself for the video, but do you consent for me to examine you?
Yes.
Okay, great. So for the beginning, I'm going to do the cardiac area. I'm going to be looking at the precardium. I'm looking for any pulsations, lifts, or heaves. Then I'm going to go ahead and assess the precardial points. There's the aortic point, which is in the second intercostal space to the right of the sternal border. The pulmonic is in the second intercostal space to the left of the sternal border. The Erb's point is third intercostal space left of the sternal border. Tricuspid is fourth intercostal space left of the sternal border. The mitral is in the fifth intercostal space left midclavicular line, and the epigastric is to the left of midline below the xiphoid process. So what I'm going to do is lightly palpate, making sure I don't feel any pulsations or lifts or thrills. And this is Erb's point. I'm sorry, this is aortic, pulmonic, Erb's point, tricuspid, and then the mitral, and then the epigastric, and I did not feel any. So next what I'll do is try and assess the apical point impulse, and what I want to do is feel over the mitral area, the fifth intercostal space, left midclavicular line. I want to feel for the area of the greatest impulse, and then make sure it's no bigger than a quarter, and it's right there. And if it were displaced, I would suspect some sort of heart enlargement. So that's the apical impulse. Next, I'm going to be listening to the heart sounds. So S1 is heard best over the apex in the mitral area. S2 is heard best over the base in the aortic area. S3, 4, and mitral valve prolapse are heard in the left lateral decubitus over the fifth intercostal space, the left midclavicular line, the mitral area, and that's heard with the bell of the stethoscope. Split S1 is heard in the tricuspid area. Split S2 is heard in the pulmonic area, and that's the only sound that varies with inspiration. I would also listen for mitral valve regurgitation and aortic stenosis, which are both heard on systole. And the way to differentiate between the two of those is the squat test. One test could be the squat test, where I would have her squat down and listen in the mitral area, and if I heard the sound diminish, then I would suspect mitral valve prolapse or regurgitation, and if it got louder, I would suspect that that's the opening snap of aortic stenosis. But for purposes of this video, I am going to do the Valsalva maneuver test. So what I'll do is place my hand over her abdomen, have her bear down, and then I'm going to listen to the left lateral border in the mitral area. So, all right, bear down for me and hold your breath, and I'm listening. And if I heard the sound get louder, I would suspect mitral valve prolapse or regurgitation. If I heard it get softer, I would suspect aortic stenosis. So now what I'm going to do is palpate all the precardial, the areas that the heart sounds with I'm going to palpate the precardial points with the diaphragm of the stethoscope. So I'm listening to the aortic, pulmonic, Erb's point, tricuspid, mitral, and the epigastric. Now I'm going to also take the left lateral border and the mitral area with the bell of the stethoscope. Right. And now if you roll over onto your left side, is that this way? Yes. Reverse. And I'm going to listen for S3, S4, and mitral valve prolapse, listening in the mitral area with the bell of the stethoscope. And now, if you'll sit up for me, and I'm going to have you exhale, Melissa, over the left lateral border and into the mitral area. Okay, exhale. Great. And that's great. And if you won't mind, oh, let me do it one more time. Sorry. Exhale. Good. All right. If you wouldn't mind laying back down, I'm going to listen for any bruits over the arteries. So first I'm going to start with the carotid arteries. I'm going to have the patient hold her breath, and I'm going to listen in 3 places, listen for a bruit. So turn your head that way for me and take a deep breath in and hold your breath. Good. And you can breathe and deep breath in, exhale, or hold your breath. Good. Great. Next, I'm going to be listening to the radial arteries for bruit with the bell of the stethoscope, and the brachial, okay, and the renal, sorry, the iliac, and the femoral. Great. Next, I'm going to assess the arteries, the pulses, I'm sorry, and I'll be assessing for regularity. So first, let me get a pulse rate in the radial arteries. And her heart rate is about 80 beats per minute. It's regular rhythm and rate. So now I'm going to be grading her pulses of between 0 and 3 plus. 0 is absent, 1 is diminished, 2 plus is normal, and 3 plus is bounding. So here in the radial artery, we feel 2 plus, brachial 2 plus, femoral will be deferred for purposes of the video, popliteal on the knee is 2 plus, posterior tibialis, sorry, 2 plus, and dorsalis pedis is going to be 2 plus as well. All right, so at this point, I'm going to assess for, I'm going to take your socks off if you don't mind. Okay. I'm going to assess for any edema. Dependent edema is edema of the lower extremities. So I'm looking at her legs and ankles. I don't see any edema. If I did see edema, I would press for 5 seconds in the medial malleolus on the top of the foot and in the shins. And I would hold it and see how long the indentation lasts. If it was a short amount of time, that would be 1 plus pitting edema. If it were a large amount of time, that would be 4 plus pitting edema all the way up. That's how you grade pitting edema. I would also look for some generalized edema or anasarca, cerebral edema, edema of the brain, or pulmonary edema, edema of the lungs. So, did not see any edema. Next, I'm going to assess for skin color, skin temperature with the back of my hand. So I'm just feeling the temperature of the upper extremities, and everything feels warm, and the lower extremities. Get your little ankles here. And everything feels warm. I'm going to assess for any tinting of the skin, indicate dehydration, and there's no tinting. I'm going to assess for capillary refill, which should be less than 3 seconds. When the fingernail bed is blanched, it should return to pink in less than 3 seconds. No, and the capillary refill is less than 2 seconds. Great. All right. So now we will go on to the abdomen assessment. So I'm going to inspect your abdomen. So I'm just going to look on her abdomen. I'm looking for any striae, dilated veins, any pulsations, any lesions, nevi, thrills, no thrills, any lesions, nevi, wounds, anything like that, any herniated areas, and nothing is noted. So next I'm going to auscultate. We auscultate the abdomen first, so not to stir up any excessive bowel sounds by percussing or palpating prior to auscultation. So I'm going to listen to all 4 quadrants. And what I'm listening for is bowel sounds Normal vowel sounds are 5 to 34 per minute. If I heard more than 35, 35 or more, I would expect that's hyperactive vowel sounds. And less than 5 is hypoactive vowel sounds. If I didn't hear anything, I would need to listen for a full 5 minutes. Borborygmy can be heard as well, and that's just peristalsis, usually indicating digestion of food. So I'm going to listen in all 4 quadrants for the diaphragm of the stethoscope. Good. Good. Next, I'll be auscultating over the hepatic and the splenic areas for a friction rub. Friction rub is a grating sound that varies with respirations. It is indication of inflammation of the peritoneal area of the peritoneal lining of the organ. It can be from a liver biopsy, liver tumor, gonorrhea, syphilis, or a splenic infarct. And if I hear a friction rub in combination with a systolic liver bruit, I would suspect hepatic carcinoma. Okay, so I'm listening over the liver and the spleen. Next, I'm going to listen for a venous hum. This is rare. It's a soft sound that varies and is heard over systole and diastole. I'll be listening over the umbilicus, the liver area, and the epigastric area, and it just indicates increased collateral circulation, and it can be indicative of hepatic cirrhosis. So I'm listening over the liver area, the epigastric area, in the umbilical area. Great. So now what I would do is assess for any type of aortic, I'm going to percuss first. So I'm going to be percussing in all 4 quadrants, and I'm listening for tympany. I'm percussing all the way across the abdomen, up into the gastric bubble and trough space. And if over across the spleen, I should hear tympany as well. If I hear any dullness, it could be the liver. That's what I would percuss over the liver. And if I hear any, or it could be an abdominal mass or some stool. So next, I would look over the abdomen and make sure I don't see any pulsations. I would check for a triple and aortic aneurysm. And if I see a pulsation in the medial area, a marked pulsation, I would go ahead and get help and not palpate any further. But since I don't see a triple A, I will go ahead and start with some light palpation. I'll be feeling for any masses or tenderness, and I'll be following the order of the colon. So I'll do a little deeper palpation. Is any of this tender?
No.
Okay. I'm going up the ascending colon and across the transverse colon, down the descending colon. Great. And you didn't feel any tenderness?
No.
Okay, good. Now I'm going to palpate and percuss the liver. Well, I'll go ahead and do the spleen since I'm on this side. So what I would do is go ahead and percuss across the spleen. I should hear tympany. And the spleen lies in the 9th, 10th, and 11th intercostal space, posterior axillary line, behind the duodenum. So, and I would try to palpate, take a deep breath in, and I'm going to try to palpate the spleen. I don't feel anything, which is normal. If I did feel anything, I would suspect splenomegaly or an enlarged spleen. Okay. Now I'm going to check the liver. So what I'll do is I'll percuss from an area of tympany all the way up to where I hear some dullness. Okay. And mark that area, and then I'm going to percuss from resonance down to dullness and mark that area. And that is usually 6 to 12 centimeters mid-clavicular line, and then across, and it's usually 4 to 8 centimeters mid-sternally. And that would indicate the liver. If you'll take a deep breath in, I'm going to try and palpate the liver as well. And I should feel some sharp border of the liver. It should not be enlarged. If it was enlarged, I would, or hepatomegaly, I would suspect that. So the liver is good. Next, I'm going to assess the superficial abdominal reflexes. So I will be checking the upper quadrant. So the umbilicus should go in towards the stimulus, and the upper area assesses T 8, 9, and 10, and the lower one assesses T 12, 10, 11, and 12. And so those are intact. Next, I'm going to be assessing for Murphy sign for any cholecystitis or gallbladder issues. So what I'll do is I'll mash my left thumb in towards the liver at the intercostal where the rectus muscle meets, and I'm going to mash in. Does that feel tender at all? No. And the patient didn't gasp when I mashed in or released, so that would indicate no tenderness or no cholecystitis. Next, I'm going to be checking for appendicitis. So what I'll do is the rebound test where I mash in the right upper quadrant and let it release. Do you feel any tenderness? No. Okay. For Roseving sign, I'll be mashing on the opposite side, and if she feels tenderness in the right upper quadrant, I would expect appendicitis. Any tenderness? No. Nope. Okay. For the obturator sign, I'll have her lift up her leg and rotate outward, and if there's, do you feel any tenderness? No. Okay, great. You put your leg down. If she did, I would expect that the obturator muscle would be pulling on the inflammation from the appendix. And if you will press your leg up against me, does that feel tender? No. Great. That's the psoas test. And if she had any tenderness, I would expect that the psoas was pulling on the area of inflammation. And I believe that concludes my assessment. If you'll just scan the room. Thank you.